parts of the reproductive system, mostly on the female side, as males are all going to basically go to sonography these days. We don't really do male exams in radiography much anymore. We'll talk a bit about them as well. Okay, so starting with the anatomy of the female reproductive system, we're going to look at the internal and external organs. And internal organs or structures actually can be seen when we introduce contrast via a method that we're going to talk about a little bit later, using those hysterosalpingogram procedures that some of you may have or may not have seen yet. They're very rare these days. We don't do them very much. Actually, in pediatrics, I feel like we did more of them as compared to what I've seen in adults, because in pediatrics, as we'll talk about later, they do that for a very, very specific reason. I'll get to that later. Don't want to spoil that because it actually has some interesting stories. So internal structures of female anatomy, we have the ovaries, we have the uterine tubes, we have the uterus and the vagina itself. And we're going to break all this down more specifically on the next couple of slides, because there's actually parts of the uterus we have to label and parts of the fallopian tubes we have to label as well that we will see demonstrated on a radiograph when we introduce contrast into that area. This is just a general overview to start with here. By the way, for the female anatomy, the uterus, one way, if you're kind of like, if you like to draw pictures like I do for anatomy, it looks like a moose.
Why are you doing us like
Looks
that?
like a moose. You don't see it? There's the head, there's the antlers.
Bless you.
I always thought it looked like a moose.
You look like a mean cat.
I mean,
Nothing. Nothing.
looks like a shark brain.
Shark brain.
Look like one of them mean skinned cats.
You've never
I mean,
It's you don't see the moose? I see a moose.
a ball
Yeah, when you show, when
Two
you,
eyes,
when you blow it up like that.
or a
look like a
deer.
goat.
Moose or a deer.
Yeah, it look like a goat blown up.
Listen, I be out there.
A cross-sided goat.
Huh?
Across, you know how them goats be looking like cross-sided? That's what it look like now since you blown it up.
I can
No,
kind of
they
see
look
that
like-
too.
Yeah.
Okay, so we're just going to follow this anatomy up, guys. This diagram, you do need to know this diagram very well, because when we do a hysterosalpingogram, it actually lights up all these organs very nice. We can make out all these parts specifically on those hysterosalpingograms. So, starting with the vaginal canal, it's going to be the most inferior structure. Moving up, we have what's called the external OS and internal OS. Now, there are four main parts of the uterus that it's divided into. The most inferior portion of the uterus is the cervix, and if you've ever had childbirth, that should be very familiar to you. That's what they look to be dilated before childbirth. So cervix is the most inferior portion, followed by the isthmus. Now cervix is actually very small. Be careful when you're labeling this. I'll say again, know this image for your image review. The cervix is only this very small portion right here. This other main part of the narrowing of the uterus in the inferior portion is going to be the isthmus. Isthmus. Yes, it with a lisp. Isthmus. Then we have the main portion of the uterus where it widens. That's the corpus or the body of the uterus. And just like other organs, topmost portion that curves into a circular shape, fundus, just like the stomach, just like the gallbladder. So fundus, body, isthmus, and cervix, sometimes also called the neck. Now we do have two linings on the uterus. You have the serosa, which is the peritoneal lining. That's the exterior lining of the uterus. Then you have the endometrium. That's going to be the interior lining of the uterus. Whenever a female's on their menstrual cycle, that's what's being sloughed off, causing all the bleeding that's associated with menstrual cycles. Because the egg will attach right here, and it'll slough off, and you, of course, pass all that tissue during menstrual cycles.
I hate to ask, but point to the cervix again.
Where's the cervix?
Yeah.
Right here. This small portion right here.
Small part.
Very small part, most inferior portion.
It looks bigger than the isthmus.
Well, I guess it is, yeah, I guess it is larger than the isthmus, I'm sorry. Here to here is cervix, just the little narrowing here before the body is the isthmus. But when you're going to label the cervix, guys, on diagrams, put it right here in the center, on the inferior portion. That's the safest spot to put your marker. Just preview of things to come. Okay, where was I? Endometrium, that's the interior walls. Now we have the fallopian tubes branching off. That's where the antlers are. I'm sorry, I'm calling it a moose. It's the moose antlers coming off the sides. And we have four parts of the fallopian tube. We have the isthmus of the fallopian tube as well. I don't know why they didn't choose another name for that, but they didn't. Isthmus is the portion that's closest to the uterus. The mid portion is the ampulla. That's where it curves. And the infundibulum is going to be the last portion of the fallopian tube before it attaches to the ovaries. there's these little finger-like projections coming off of the infundibulum called the fimbriae. Fimbriae, little finger-like projections. Now those are going to be important for our hysterosalpingograms because when we inject contrast through the uterus, we actually want that contrast to go all the way through the fallopian tubes and dump out of the fimbriae into the peritoneal cavity. Why do you think that's desirable? Why would we want the contrast to actually go all the way through and dump out into the peritoneal cavity? Anybody know? Why would I want contrast to go all the way through the uterus and dump out of the fallopian tubes? To make sure they're working, correct. Because if we do not have contrast coming out of the fimbriae, that's indicative of a blockage of the fallopian tubes. That can actually cause a lot of issues for a female. A lot of times, they'll have to just have those completely removed if there is a severe blockage.
So
Of
will
course.
it be like a reflex? You know, like will it come, like stop and come back, like reflex?
Oh yeah, it would literally get clogged up and come back out.
Okay.
Yeah, you actually want the contrast to stay and go all the way through for those examples. We'll talk more about that in the procedures. So one more part we didn't talk about, guys, the actual connection of the fallopian tube to the uterus is called the interstitial. That's like the little joint, so to speak. And then the ovaries themselves. Ovaries are where the eggs are created. That's the path, by the way, guys. Eggs are released to the fallopian tubes, attached to the uterus, waiting for fertilization. If they're not fertilized, they're passed during the menstrual cycle. And females have limited eggs. You only have a limited amount of eggs that you'll make throughout your lifetime. Whereas males, they can procreate their whole life. Y'all should already know that. Cornu. Cornu, don't worry about cornu. They don't ask you about that one. It's just another like little part of that joint space where it's connecting.
Do we have to know that ligament?
Which one? We don't see it on an image, so I would say no, but just know that's how the ovaries are attached to the uterus. Otherwise, they would just kind of fall off and lose all your eggs. That's how it's staying in place.
So what happens when they move you to take uterus out? and
Like
leave
a
leave that?
why did I say a histogram? Gosh, what's it called?
Hysterectomy?
Hysterectomy. Thank
Yeah,
you.
so
My
what
wife
happens?
had a hysterectomy. I should know what that is. So yeah, hysterectomy is when they remove all the uterus, but they leave the fallopian tubes.
Yeah, that's what I'm wondering. So what they hanging on to after that?
They're just kind of floating in there.
Really?
They attach them to like the peritoneal walls, but
Huh.
they keep them secure. But
So
Oh my
the
gosh,
egg
they have to go over there and
inside the
take a
ovary,
look and
it's
then
like
see
one
what
from
it
each
looks like.
side, like every other month, right?
yes,
It's supposed to be like
supposed to be.
6
Yeah.
years.
Some women
6
produce
years.
more. Some produce more and go through the eggs faster. That's why some women are more susceptible to having twins, because if both eggs are coming down the tubes, attaching, and then of course fertilization occurs, both eggs get fertilized. That's how you get twins. Mm-hmm.
Or if one, like it can be the one get
Or
fertilized.
also one egg can get fertilized by
And
two
then-
sperm.
and have
So
this
that would be your
identical
twins and your
Fraternal.
Alright, Monty, that's you, alright?
your what's the
Fraternal.
word? Fraternal twins is when you have two eggs.
Yes,
Thank
sir.
you.
So
Thank you.
identicals are 2 sperms and then.
Identicals are 2 sperms into 1 egg, and fraternal are 2 eggs, 2 different sperms, 2 different
Oh,
sperms.
Okay, got
Mhm.
it.
And of course,
I thought it
triplets
had
and
to do with
quadruplets
their
and all that
size.
as well. I had a patient. I think I told y'all at TCH she had 8 kids.
Oh, like a
I
cat.
think that was called octuplets.
Oh, come on, that
Yeah,
was-
that was one of my
In
last
vitro?
weeks.
Was that Kate with 8 or whatever that TCL?
I don't know if that was the same
Eight and
person, but
nine.
it was one of my last weeks working there.
All
I
8
did,
survived.
I did the X-rays on. They were all healthy babies
They
too.
all survived.
They all survived. They were tiny, but they all
Was
survived.
there
Was it that
pound
lady
each or
that was on
less?
Oprah?
They
That
were
crazy
they were
one that had more kids?
tiny,
Yeah,
tiny,
less than
tiny.
a pound.
Octomom? Yeah, that one.
Mhm.
I think so.
But there everything developed in.
Talking about
Yes.
you ain't got no job?
Yes.
Yeah.
Okay, so we're gonna break some of these parts down more specifically, guys. Talking about the ovaries first. That's 2 small glandular almond-shaped organs on each side of the lateral wall of the pelvis. Now, the internal secretion is what controls your menstrual cycle. External secretion is going to contain the ova or the female reproductive cells. So it's a combination of that internal secretion and external secretion, as those eggs move from the ovaries down the fallopian tubes and attach to the uterus. And once again, if those eggs aren't fertilized, it sloughs off, and that's how you have that menstrual cycle occurring. That's what it's called, sloughing off. It sloughs off the tissue.
That's what it feels like.
I'm sure y'all feel like it's a slough,
Yeah.
all right? My wife always tells me, she says, that's the one thing she doesn't miss about her uterus. She's like, I don't have periods anymore. It's so
Yeah.
nice. So,
Smart way.
so yeah. Huh? So as far as the makeup of the ovary, guys, no more so what it does, because we can't actually see the ovaries on an x-ray. That's one part you kind of omit from knowing all the parts. Now if you go into ultrasound, you're gonna know all these parts of the ovary. They can see all the little, there's a lot more than what's labeled here. But we're just gonna describe what they do for the purpose of x-ray. But everything else, like the fallopian tubes and the uterus, we're gonna see all that on contrast, so we need to know how to label and of course what it does. Reagan Al right over there, she passed out. Someone wake Reagan up. What'd I get you that water for, Reagan? Oh, she didn't even move. They're making sure you're alive over there. I got you water so you wake up. You're missing all this action about ovaries. Yes? Say again? Internal secretion. So the internal secretion is going to be the sloughing of the endometrium, whereas the external secretion is going to be when the egg passes from the ovaries down the fallopian tubes. So it's a combination of those two that cause the menstrual cycle. All right, so the little parts here, guys, like I said, don't worry about labeling these on the ovary, just know what they are per definition. Medulla, that's going to be the core of vascular tissue found in the ovary. The cortex, just like the kidney, the outer glandular tissue that has those ovarian follicles. Each one of those follicles, by the way, contain one ovum. And what's the ovum? That's the eggs. And of course, every female has a limited number of eggs. So each one of those follicles, there's a lot more than what you see on this picture, by the way, contain one of those ovums until it's ready to pass down the fallopian tubes. We have the Graafian follicle. That's a fully developed ovarian follicle. That's when the eggs get ready to release. Ovulation is going to be extrusion of the ovum by a rupture of that follicle. And that occurs during your menstrual cycle. And it's drawn down towards that uterine tube. Of course, as it moves down that tube, it attaches to the uterine wall on the endometrium, awaiting a sperm to fertilize it. Otherwise, it is passed.
Being that this isn't something that we can see on X-ray, is this fair game on hotspot? Like, do we have to know the diagram?
Not for the ovary. For the all this, yes.
Yeah.
Ovaries, you can omit. Just know what the parts are and what they do, per definition. Ultrasound, though. You ever go to ultrasound? Yes.
That's too much.
That's too much.
I'm trying to understand an IR.
Hmm?
I'm an IR and I'm trying to understand it.
Ultrasound,
Johnny's trying to teach me.
like ultrasound.
They do ultrasound
Their
there.
images, they look a mess to me.
Yeah, I'm like.
They're hard to see what
Like,
you're.
oh, look,
I don't.
this
I
is
don't.
the kidney right there. I'm like.
I don't know how they know what they're
I was
looking
like, where's
at.
the needle?
You're like that white thing or the black thing?
So
Where's
uterine
the
tubes,
needle?
guys. Uterine tubes, of course, I didn't say this before, but uterine tube is another name for fallopian tube. Fallopian tube being the most common terminology that we use, but they're also called uterine tubes. They're going to arise from the lateral angles of the uterus, opening up into that peritoneal cavity. They collect the ovum. By the way, remember the ovaries are connected right here. They collect the ovum and it travels down the fallopian tube towards the uterus, not the other way around. Some people think it comes from the uterus and goes out the fallopian tube. It doesn't work that way. Opens up into that peritoneal cavity. They collect the ovum released by the ovaries and convey it to the uterine cavity on the endometrium. And they're approximately 3 to 5 inches long on each side, with a small diameter at the uterine ends. By the way, fun fact, did y'all know that the ovum is the one human cell that you can see with the naked eye?
Really?
Without a microscope? Now you know. That's the one human cell that can be seen with the naked eye, which is pretty cool.
Pretty big.
Still pretty tiny, but you can still see it without a microscope. Little speck.
Peritoneal cavity of what?
Hmm?
Opens into the.
Just into the open space.
Okay.
So nothing really should be traveling through there unless we're introducing contrast, but of course we're going to use non-ionic contrast. Tissues will absorb it into the bloodstream. It's still safe.
So whenever there's you know those pregnancies that we have them in the
I was about to talk about that. So a pregnancy where the egg gets lodged in the fallopian tube, it's called ectopic pregnancy.
Oh my God, yeah.
Can be very, very dangerous. In fact, my sister-in-law almost died a few months ago from that. She had an ectopic pregnancy and didn't know. and didn't go to the hospital, they actually said had she waited any longer, it would have ruptured inside her fallopian tubes
How
and
many
killed her.
months was it discovered, sir?
Hmm?
How many months was it discovered?
Quite a ways along. I think it was a few months, maybe like 1 or 2 months along. So it was growing in there and it was lodged, and they said it was about to rupture. So very, very dangerous. That's accompanied by a lot of severe pain and bleeding, by the way, if that ever occurs to you. Severe bleeding and pain in the abdominal area, go get that checked out. You never know. Better safe than sorry, because that can kill you if that does rupture. So very rare, but it does happen. So the sperm actually ends up fertilizing the egg in the fallopian tube, is what happens with that.
But are they viable pregnancies or not?
I mean, they could be if it was able to grow, but because it's stuck, I mean, yeah,
There's no way for the placenta
it's
to
gonna-
go in the tube either.
yeah, it's
So
not gonna be a
just-
viable pregnancy, no. Okay, so there's those parts we just talked about. Again, guys, the parts of the fallopian tube. Isthmus, once again, being that short segment near the uterus where it attaches. Ampulla being the midsection, which is the majority. And the infundibulum is going to be the termination point, lateral portion, and it's actually flared in appearance. That's your moose horns. I'm still going to call it moose horns. I don't like it, I'm going to call it moose horns. And of course, at the end of each of those infundibulum, we have the fimbrate, those little finger-like projections coming off the ends. And once again, when we're doing the contrast studies, we're actually going to follow that all the way through here, and we want that contrast to dump out of the infundibulum. That's a good thing. It's not, it means we have a blockage going on.
When you say dump out, you mean it's like a trickle?
It's actually going to well, it's going to be more than a trickle. Quite a bit's going to come out, yeah. Well, ovaries are attached just right here, but you have a little opening over here as well.
Oh.
Mm-hmm.
Round ligament, is that what they say that the baby kicks? And you got like
That is
round
one of the parts,
ligament pain?
yeah,
I had that.
it is.
It hurt.
Remember, the baby's actually sitting upside down most of the time and usually kicks right there. So, yeah.
I did.
All right, so anatomy of the uterus is a sagittal view of the uterus here. Pear-shaped muscular organ. This is going to be the central part of the pelvic cavity. Now, please know the position of that uterus in relation to the bladder. That's something people often mix up. Uterus is posterior and superior, not just posterior. Posterior and superior to urinary bladder, which is why you always get that joke that when you're pregnant, you always got to go to the bathroom because the baby's lying right on top of your bladder. Right on top. As that uterus expands, it's expanding on top of your bladder as well. I can't relate, but I imagine that's very uncomfortable. Yes? Yes, no?
Yeah.
I imagine it's very uncomfortable. It's also anterior to the rectal ampulla, and the uterus is usually approximately 3 inches in length. It's actually quite small, quite a small part, but it expands greatly as that baby grows inside of it, which is kind of amazing that it expands pretty much like a big balloon, quite
And then it goes
large.
back.
And it goes back down, shrinks right back down. Mhm. So here's all the parts we've named so far, guys. Vaginal canal right here. And by the way, just remember once again, bladder's anterior to the vaginal canal. You go up, here is the cervix. You remember what the next part was? Isthmus. Mid part was the body. Oh, wait, I'm in the wrong part, I'm sorry. Cervix right here, isthmus right here, body. Top part of the uterus, fundus, coming off the sides. Fallopian tubes, and make note here, guys, fallopian tubes, even though they're coming off the sides, they're still a little bit superior to the uterus as well. So if you're looking at it from the side view, they look like they sit right on the top of the uterus, but they are branching off the side as well.
Second show isthmus again, please.
Isthmus, yeah, so vaginal canal, cervix, isthmus is right here, body, and then fundus where it's rounded at the top.
Cervix is just the opening.
Cervix is basically just the opening right here, yes. Isthmus is still where it's narrow. Then body is the main part of the uterus where the endometrium is. And then your fundus at the very top. You all remember the parts of the fallopian tube as well? First part was the isthmus, followed by the ampulla, and then the infundibulum. All right. So 4 parts. Once again, guys, there's your 4 main parts of the uterus. Fundus is the blunt, rounded superior portion, the most uppermost portion of that uterus. Body is what narrows down from the fundus to the isthmus. Isthmus is considered the superior part of the cervix. It's a constricted area between the body and the cervix. And the cervix itself is the cylindric vaginal end of the uterus. And once again, that's what they check whenever you're about to give childbirth. See if that cervix has dilated to a large enough amount for the baby to pass naturally during childbirth. If not, of course, they do a C-section. You know, when my wife had that traumatic childbirth, they said her uterus just basically died. It just completely died, like lost all blood supply, which is why they had to remove it. Because she lost so much blood from bleeding, it just wasn't getting enough blood, so it just basically just like the tissue just died. She said she doesn't miss it though.
But she doesn't. Man, I don't think you've been through a lot. Is she okay?
She has. She's Superwoman. She really is. She takes a licking and keeps on kicking. And you would never know anything was wrong with her either. She's super tough like that.
Is she
I
gonna
went-
be at our graduation?
I'd like for her to be, so she can meet y'all. And she went through all that stuff without painkillers either. They had to turn her
Oh,
epidural
because
off.
of her heart rate?
They had to turn her epidural off. Yeah, she is a superwoman, let me tell you. I couldn't do it.
Why did you turn off the epidural, sir?
It was affecting her heart. She has long QT syndrome, and it was causing her heart to go into arrhythmias.
That must have been tough.
All right, to wrap up the uterus here, guys, uterine cavity appears triangular. Actually, does look like a triangle on our x-rays when you fill it with contrast. When viewed in the frontal plane, canals dilated in the center, constricted at each end. Proximal end is continuous with the isthmus. In the endometrium, once again, that's the inner mucosal lining of the uterine cavity where the eggs attach. And cyclic changes occur there during your menstrual cycle up until menopause, whenever you stop producing eggs. So now, you know, whenever it's your time of the month, you can say, my endometrium is sloughing today. Anyone use those scientific terms?
Like
Confuse
somebody would look
everybody?
at me like,
Like, your what? Your what's doing what?
that's just necessary. So like endometriosis?
That's like an infection.
Oh, thank you. I'm not educated on that.
It's okay. So that can get infected in there during the sloughing process, and can get very swollen.
I know it's like really painful.
I would imagine so.
If my cousin has it like really bad and it's hard for her to get pregnant. So she had her first one and now she's on her third.
And not to be gross, that's why hygiene is very important as well. Some people that don't practice very good hygiene end up with a lot of infections in there. And I'm sure you've had some patients that don't smell very good downstairs. They're not doing much hygiene. Yeah, it's kind of gross. True. Some people that aren't homeless though, they still don't clean out there. Male or female. Hit you in the face with that smell. Whew.
Mr. Donahue, I'm sorry, this is like way off the wall. Okay, the other day I did like, cause they're just now like letting you like do your, well, for me personally, like the portables like by yourself. So I went in to do my KUV and I took like the lower one and this man had an aerosol can.
I heard about this story. Javier sent me the picture.
Yes.
Let
Do
me
you have-
see.
Do you have the number? He said you have the number.
Yeah, I do.
We need to pull that up before the end of class, because I saw that. It's humongous.
I don't have it on me though. Is that-
Oh, epic fail.
Did he send it to you?
He did send it to me.
Go on, find
Yeah,
it.
I saw it. I was gonna email it to myself.
Come on,
Almost looks like a
Randy.
Photoshop.
Oh my god.
Whoa.
Almost looks Photoshop.
Ready to fall on it?
Yeah, aerosol can. Up the rectum.
Oh. Was it Elaine?
Yeah.
Oh.
It almost looks like a Photoshop picture, but it's
Damn.
real. It's real.
Baby.
All about the money.
All right, so the testes or testicles, they go by both names. Not the term one of y'all use in class one day.
I've been waiting for it.
The testes produce spermatozoa. What's a spermatozoa?
Sperm cell.
Sperm cell. It's a sperm cell, a single sperm cell, spermatozoa. Of course, there are millions of sperm produced by the testicles. They are dual ovoid bodies. A man can survive with just one, by the way, and still have kids, but most men have two, unless they've had it removed. They are approximately 1.5 inches to 1 inch in width and depth. They have 200 to 300 partial components that constitute the glandular substance. That's where the spermatozoa are manufactured and created, and of course kept at a certain temperature. Each compartment houses one or more convoluted germ cell producing tubules, and they unite to 15 to 20 ductiles or ductules that exit the testes and enter the epididymis. So all those little sperm cells are produced in both those testicles via this glandular tissue. And once again, just kind of give y'all a visual of what happens when that gets twisted. The ductus deferens and the epididymis becomes twisted and actually gets blocked off. And there's a lot of blood flow going down here. All that blood's gonna start pulling up in here, causing that all to swell up. And it could completely kill the testicle. That's having it removed.
What's your word of
My word of the chapter.
yeah, usually have like a favorite word of whatever we're going on.
Oh, it's coming up on the spine.
Yeah.
It's on the spinal cord. There's one on the spinal cord I love. It has a fun name.
Like mine is epididymis.
Epididymis, that's your favorite one?
I think so.
All right, then we're about to talk about the epididymis. There you go, epididymis, your favorite word of this chapter. There you go. That's attached to the superior and lateral posterior aspects of the testes. This will be the main duct, continues with the ductus deferens. And that is what is going to start transporting the sperm from the testes to the vas deferens as we move up the body. So that's the first point of transport of the sperm cells. Huh?
Emily.
So where the sperm stored? They stored in the
Sperm is stored in the testes, yes. When they're released, they come down the epididymis, move up the ductus deferens, and we're going to follow the path as we go through the rest of the anatomy here.
And where are they produced from? The sperm?
They're produced inside the testes
Also
via
produced
glandular
there.
tissue. They're manufactured inside the testicle, yes, and they're kept there until released. Now, sperm, if they are not released, they actually die in there, and they're recycled, like the body reabsorbs them and creates more. They die. They actually die in there, yeah. Sperm are only viable for, I think sperm are viable up to 5 days, yeah. 5 days. The body reabsorbs. Reabsorbs.
Yeah.
And I think at least they get it when the woman's egg die,
At least what?
they get reabsorbed.
Reabsorb. The cells die, the body absorbs the dead cells and reproduces more sperm
And
cells.
more will come up.
All right, so from epididymis, we're going to go to the ductus deferens. That's these little thin little tubes right here. So those are 16 to 18 inches long. They extend from the tail of the epididymis, which is right here, to the posterior inferior surface of the urinary bladder. So they go way up here on top of the bladder. They ascend along the medial side of the epididymis on posterior surface of the testes. They join with the spermatic cord, and they emerge from the scrotal sac, passing into the pelvic cavity and expand into an ampulla. That ampulla, which is right here, so it goes all the way up, curves up on top of the bladder and behind the bladder, People don't realize that's the path a lot of times. It goes all the way up on top of the bladder, behind the bladder. It's gonna go into the ampulla, and it's gonna be a reservoir for seminal fluid. So sperm cells, as they are moving from the testes up towards that ampulla, they don't actually get mixed with fluid until they get to the ampulla itself.
Where's the tail?
Hmm?
Where's the tail?
Tail of the epididymis. Here's the epididymis, here's the tail. And as you go up, that's the ductus deferens. So all the way up on top of the bladder, behind the bladder, enters the ampulla. And ampulla is where fluid's gonna start being mixed with the sperm cells. Uniting with the seminal vesicle, which is what we're gonna talk about next. So know once again what these are, as well as how to label them. Know the functions of these parts. So that's your transportation of your sperm cells, essentially, before it mixes with fluid.
Is ampulla just like its own thing, or?
It's like a little chamber before you get to the seminal vesicle. Stores the sperm cells when they start mixing with the fluid in the seminal vesicle.
So it's between the seminal vesicle and the prostate?
Well, prostate, we're not, yeah, that's before the prostate. So these are kind of like right in the same area essentially. So you have your ampulla where the sperm cells are stored, and this vesicle is going to start dumping fluid in there and mixing the sperm cells as it's stored in there.
Oh, the fluid comes from the seminal vesicle?
Yes. All right, there's the seminal vesicle. It's about 2 inches long. They are located obliquely on the lateral-posterior surface of the bladder. So if you see back here, you have 2 of them, by the way, 2 seminal vesicles. A junction with the ampulla of the ductus deferens, forming the ejaculatory duct. And once again, that's what produces the actual fluid that turns into semen. So there's those ductus deferens once again. They're coming from way down the testes all the way up, over the back, over the top of the bladder, behind the bladder, and then it's going to gather in these ampullas. These are where the sperm cells are gathering.
Bless you.
Seminal vesicles are then injecting fluid into the sperm cells and mixing them at this point before we get down to the ejaculatory ducts. So a lot going on in there.
Does all of this go on like since childhood? Or does it, like, you know how the
So
view?
no, you don't.
fuse
So
and stuff, or-
male doesn't start producing sperm until puberty. So this is not
Okay.
happening.
But like it
Uh,
has like all the moving parts.
The parts are all there, but they don't actually start producing sperm until puberty. So this is a posterior view, by the way, looking behind the bladder.
All this is behind the bladder.
Hmm?
So all this is behind the bladder.
All this is behind the bladder. Once again, here's the path: testes, epididymis, ductus deferens goes up in front of the bladder, over the back, behind. Sperm cells are stored in the ampulla. Seminal vesicles then mix with those sperm cells, creating the seminal fluid. The start of the seminal fluid, because you're gonna get more from the prostate here in a little bit.
So puberty would be between 9 and 14.
What's that?
The age for puberty is 9 and 14.
Varies. Okay, so ejaculatory ducts is going to be the next part here, formed by the union of the ductus deferens and the duct of the seminal vesicle, originate behind the neck of the bladder, these little tiny little ducts here, enter into the base of the prostate, and those are going to eject the sperm into the urethra before ejaculation does occur. It's the ejaculatory ducts. So there's going to be one last stop at being the prostate, where it's going to do that final mixture of fluids to create the sperm before the semen with fluid before it actually gets ejected out of the body. Okay, then we have the prostate. It's going to be the last stop. It's going to be that colonsate genital organ that is part of the reproductive system, even though we talked about it with the urinary system, comprised of muscular and glandular tissue, and encircles the proximal portion of the urethra right here. Extending from the bladder neck to the pelvic floor, and that's going to produce the fluid that nourishes and actually transports the sperm out of the body. So we have 2 points of fluid concentration being mixed with that sperm. So some review questions before we talk about some actual procedures. That's the end of the anatomy of the reproductive system. Vaginal end of the uterus is the what? Those parts you see listed there. In other words, what's the most inferior portion
Cervix,
of
sir.
the uterus?
Cervix.
Cervix. Cervix, correct. The junction of the ductus deferens and the seminal vesicle forms the what? Ejaculatory duct. Ejaculatory duct, correct. So know the path of how that sperm is transported. Know the order. It's going to be asked on your test. And now we're going to talk about some procedures. So you'll notice a lot more on the female side as compared to males. Males just go to ultrasound. Females got a lot more different procedures we're going to talk about. So of those, we have the hysterosalpingograms, or HSGs, pelvic pneumonography, vaginography. We have the fetography, pelvimetry, and placentography. Good Lord, these are hard to say. Placentography. So, of course, the last three are when a female is pregnant, whereas the top three are when a female is not pregnant. And that's going to be very important because we would not do those three procedures at the top if the female was pregnant. Reason being, those are fluoro procedures. We don't want to be exposing a baby to that much radiation while the patient is pregnant. So these, why do you think we would do these? Emergency cases, or if the baby has expired. So we'll talk a bit about that moving forward. Try to say it nicely when the baby dies.
She's not trying to say it that way.
You don't like when I say dead baby.
She's not trying to say
Yes.
it.
HG, right?
Yes, it is. On the HSGs.
Like a coop of it.
What y'all putting those notes away for? It's gonna be
I mean, you gotta check the date that's printed on the forehead.
And I'm
You'll have to miss some important notes here, especially this HSG. The registry is asking a lot about that HSG.
I'm all right.
I think they were trying to do one in Florida one day, but the doctor had inserted, you know, that thing with that thing in the OBGYN. And he's like, Miss Quinn, come look at this. And I guess she had so much discharge and they gave her antibiotics and they're like,
Oh.
go on with your day.
Oh, damn.
That's a contraindication when that happens. Yeah, that does happen. When you want discharge. Yeah. Okay, so HSGs, guys. Main reason we're going to do these, three main reasons. And I'm going to add a, yeah, I did have the fourth one there. Okay. So determine the size, shape, and position of the uterus and the uterine tubes. Delineate lesions, because there can be polyps and tumor masses or fistula tracts in the uterus. Very scary there, fistulas, because what would happen is the uterus will get connected to the large intestine and fecal material can pass into the uterus. Very dangerous condition there. Investigate patency of the uterine tubes in patients who are unable to conceive. To check how well they work. To make sure they can conceive. And then the weirdest reason, and this is what I used to do at TCH a lot, well not a lot, but a few times, can be used prior to sex assignment surgery. So there are rare cases whenever a baby is born with both genitalia, male and female, and parents have to make a decision of what they want the child to be. So they'll do these exams, basically say, well, to let you know, the male parts work better than the female parts, or the female parts work better than the male parts, but it's ultimately up to you what you want the gender of your child to be. In some cases, they both work fine. And they have to make a decision, do they keep both parts, or do they assign a gender to the child? I saw with about 5 cases when I worked at TCH.
They can wait.
Hmm?
They can wait to decide whether.
They can wait, but they do leave it up to the parents currently, at least in this state they do, to choose that.
Because what if you know, choose a boy, but then it ends up like.
Well, if they, usually what will happen if they choose boy, they're gonna remove the female sex organs. So
Completely?
the boy would produce testosterone and not
Yeah,
estrogen,
but
so.
what if the boy wants to do early?
If what?
Later in life?
Yeah.
But if they want to later in life, well, that's up to them. That's, but, huh? But I saw about 5 of these at TCH, and it was kind of interesting, because I was like, that'd just be a hard decision as a parent to have to decide that. Like, I couldn't imagine being put in that situation. So,
Particular child would have the vagina as well as the.
yes, both organs. In some cases, both would be fully developed. So,
The
in some of the
vagina
ones,
will stitch it up properly.
they would. So in some of the ones I saw, like one or the other would not work properly, so it'd be an easier decision. Well, like, okay, well, the uterus is not fully developed. They have more of a fully developed penis and testes, so that'd be like an easier decision. Yeah, we want to give them something that works. But in some cases, both would be working perfectly fine. So they have to make a decision of which they want it to be.
Wait, so do they have
So-
a vagina and a penis at the same time?
Yes. So it's called a hermaphrodite.
I've never
Lady
seen
Gaga
that
is a
before.
hermaphrodite.
Huh?
Lady Gaga is a hermaphrodite.
Is she really?
For real?
I did not know that. Interesting.
Go ahead.
Here.
She
Yes.
made that
So
up.
in the cases they had to choose,
Wait, a question I can't hear.
in the cases they had to choose, if you were able to follow it, what do they mainly choose? Do they mainly choose boys or girls when everything was working fine?
I saw about 5 in my career, and it was like half and half.
Oh, okay.
Like I said, most of the time it was a little easier with the case of one that I saw where both were perfectly intact. And from what I understood, they kind of just flipped a coin on that one. But the other 4, it was cases of, well, the penis is fully intact, but the uterus is like underdeveloped. So they're like, okay, well, let's go with what works
Okay.
best for the kid. So in those cases, it was a little bit more of an easier decision, but it was really kind of like divided down the middle, at least from what I saw. Yeah. Okay, we'll end there today, guys, because actually this this exam is very important for your registry, so I don't want to rush through this. They